I do want to mention right off the top that I'm not at all ashamed of the fact that I have been a real evangelist for the use of the technologies that we're now appropriately trying to fix. And if you think about it, over the last 2,024 years, for 2,000 of those years, and actually quite a bit before that, medicine never used any of this stuff. So it's very, very recent. And so what we're doing now is a little bit of learning how to improve a technology that's really still very much in its infancy. And then we heap on top of that what we're going to discover with AI. So I've been asked to answer the question, will AI solve the problems of clinician burnout and health disparities? My answer is still going to be no, but we'll talk about why that is. Kurt Langlock, who was at Stanford, used to be at Penn, has this quote that went out for a while. Some of you may have heard it. Artificial intelligence will not replace radiologists, but radiologists who use AI will replace radiologists who don't. This I believe to be true. I believe AI will not replace us, but that those of us who don't use it should begin to be concerned. So my recommendation would be, and I've given this recommendation quite a bit, make it tonight. Go to openai.com and ask it 4 random questions. It can be the poem question. It could be 4 arbitrarily deep questions about something you know a lot about. It can be translating into another language. It could be a picture. It could be some other things. And just learn enough about how it works that you're going to be intrigued by it and try to use it more often. If you're using Google searches these days, you're seeing a little hint at Gemini that shows up as part of the answer. So you might be realizing it's doing pretty well. It answers a lot of questions quite well, and more recently than these other tools. So today what I'm going to talk about, I'm going to start by the promise, then we're going to talk about the challenge, and then this cautionary tale. So I'll just say that this has been a slide that really means a lot to me, which is, as a pediatrician, I've always been very excited about what it was like to have a relationship with my families and my patients and sitting on the floor and playing Legos and drawing and interacting. So for me, the promise of healthcare had always been that this is what I got to continue to do throughout my career, and that all of my other doctors would be similarly engaged in my care as I've gotten older. But the reality is burnout, right? So burnout is defined as emotional exhaustion. It's nearly 60%, you'll see some numbers in a second, emotional exhaustion, depersonalization, which is essentially this lack of empathy that is driven into the way we typically practice, unfortunately. And then the last is this feeling of decreased personal achievement. Everybody's facing it, and if you walk around any hospital, and especially if you've walked since the pandemic, where people were just really exhausted and it just never ends. So where we are now is that 54% of doctors and probably a higher percentage of nurses say they're burned out, 88% are moderately or severely stressed, and 59% of doctors wouldn't recommend a career in medicine to their children. That number has gone up from 33% in 2022 to that number in 2024. This is what it looks like. I won't read all of these things to you, you can read them, but there's a great video that Christine Sinsky and the group from the AMA have put out, sort of describing what burnout looks like as a way for people who don't necessarily experience it or don't think it's really affecting them to see all the ways in which it might be affecting them. The fact of the matter is burnout is a systems issue. And for those of us who've experienced it, I think you'll appreciate that there's clearly this external environment in which it lives that doesn't always make things favorable, maybe scheduling issues, maybe other activities, it may be regulation. There's the organization in which one practices, and then inside of that there's this frontline care delivery system, all of which is moderated by your individual or mediated by individual factors. You know, I'm a part of the sandwich generation, my dad's in the hospital as we speak, and all of that's always on my mind while I'm trying to do every single other thing that we have to do. You add to that a full day of patient care, and it's no surprise. So based on that, there are outcomes. Those outcomes may be burnout, they may be professional well-being, and the consequences are very broad. They affect patients, clinicians, healthcare organizations, and society. Hopefully we will do more to learn how to mitigate that, and that will come back into the system. That's the goal. This is from a National Academy report. The work factors that they have, I won't read this list to you, but you all know these, right? So the work factors that are related to burnout typically relate to both the job's demands as well as the supply. How many ways can that job be tackled? And what I typically hear is our staffing is going down, the expectations are getting higher, and that basically means both sides of this slide are affecting people. People have talked about the electronic health record as a big part of the experience of burnout. And this is a study that's now been really well quoted or cited. It's been actually repeated a couple of times using a tool called the System Usability Scale to assess common technologies. And if you can't find the EHR on the slide, I've made it easier for you. It's a solid F, not acceptable, and it's in the lower 10% of usability of anything in your life. That is a byproduct of the speed with which we got to where we are from the 8% number to about the 85% adoption of EHRs since 2009. So that's what happened. Burnout is related to a few factors. This is one of my favorite papers. This is actually data provided by Epic to a number of us. Full disclosure, just so you can appreciate, this is such a hot moving area. 2 groups were actually tasked with trying to write this paper. I was one of those 2 groups. This group that published was the other of the 2 groups, because we were suspect of some of these data, but at the end of the day, this is still the same message, which is what you see in dark green is the note length of international practices using Epic. Same system, same cut and paste, same everything else. Everything that you see in light green is the note length for us. Notice no overlap, or virtually no overlap, and if you read the numbers, it's roughly 3 to 5 times longer notes in the United States than it is internationally. And many of us know why, and this has been something that CMS has attacked through changes in the E&M coding and some other things that have been done, and they are generating relief. What we also know that has not yet been published widely is that only about 30% of clinicians have changed their templates that generated these long notes, even though the billing codes have changed, because they just haven't had the time to deal with changing their templates. So that's the story of burnout, and we're gonna come back to it. Then health disparities is actually in some ways easier. I only really wanted to put a couple of slides on about this, and then you're gonna see that everything else sort of fits together. So when we think about health disparities, CMS recently passed legislation that requires reporting of this from many organizations, but these are the main 5 health disparities, which are food insecurity, interpersonal safety, housing insecurity, transportation insecurity, and utilities. And utilities meaning all of the resources that might be necessary to have a normal, typical life. So whether that would be access to gas, cars, whether that would be access to heating and air conditioning, so it's everything. And this website called SIREN, or Social Interventions Research and Evaluation Network, is actually cited by CMS as one of the best resources to access the tools to complete these measures. So the impact of all of that on the healthcare workload, and especially those disparity issues, is that although most of us knew those existed, most of our patients don't ask us those questions because they suspect there's nothing we can do about it. So now we're going to be asking these questions. Probably our nursing staff will. It's a series of yes/no questions. And anything that we wanted to try to do right now to address healthcare disparities is going to require first having the bandwidth that we lost with the burnout problem, right? But these are the types of things we're going to have to do. We're going to need time, space, and personnel to implement social and behavioral determinants of health screening processes in our sites. That means adjustments in the workflows, adjustments in the staffing, new ways to have data collection and patient inquiries. Obviously, we're going to have to be trained. I can still remember when I was in Tennessee that we heard around the time of Meaningful Use 2 that we needed to start recording sexual orientation and gender identity, also known as SOGI, across our clinics. So we went to some training programs about this, and one of the people who's in charge of training our front office staff said, we don't even ask about sex, period. Like, we don't ask patients about that. And by the way, many of you may know that in Europe, a lot of these questions are simply never asked because they're not felt to be that relevant. But the point was, people were terrified of what it would take to be on the front lines, asking people who sometimes have anger management issues, maybe are feeling very defensive, these highly personalized questions, personal questions, and you can imagine what it will take to really train this group. So although some people have been voluntarily doing it since 2023, we can expect that there's going to be an enormous amount of effort here, and this may be where the AI tools can help us. And then there's going to need to be some education about both asking the questions and also communicating why they might be important. And then finally, if you ask the question and you don't have to actually know the answer, Frank Oski, who was a pediatrician who trained me and many others in the world, used to have this question called, or a statement called, "That's picking your nose in public." Anybody else ever heard this one? He said, "It's picking your nose in public because if you find something, you're not going to know what to do with it." So the biggest challenge here is when we ask the patient, and the patient says something about food insecurity, and they have type 2 diabetes and a BMI that's off the charts, and we want to talk about how they need to change their diet to include fruits, we will have no idea how to tell them to do that. We'll just be making yet another promise or recommendation that can't be followed. So lots and lots of challenges with this work. Again, possibly amenable, we'll talk about that. And then there's challenges and solutions, you can see them below. They include the reporting challenges, they include the fact that a lot of this information turns out to be an unstructured data in the current record system, and most people don't have the access to tools to pull out structured data from unstructured data. There will be inaccurate data, there will be no report because patients are uncomfortable discussing this, they don't perceive any value, and obviously the people asking won't want to probe, and there'll be this issue of data auditing and screening personnel, so it's an enormous impact on the healthcare workload. So, along comes generative AI, and I've talked about it briefly, but just to restate, generative AI is the class of problems in artificial intelligence where we take some type of information token and we use a library of 1 billion or more, trillion, larger than 1 trillion, other representative strings of tokens to predict the next most likely token given the previous token. So if I were to say to you guys, just to practice this, "Hello, how are," what's the answer? Right, you've just done generative AI. You had no idea what the word could have been. It could have been, "How are our presidential candidates doing today?" But you didn't say that. You said "you" because it's the most common next word. Imagine a mathematical way to do that with every single word in every single language in the world, basically, and that's actually what GPT-4 does. So that's the bizarre miracle here, because it was built with one set of data initially, which is the public internet of 2021. Actually, 2020 was the first one, but nobody used it, so 2021 is the one you saw first. And even the people at OpenAI who used it, Peter Lee, Eric Horvitz, others, said, this is literally a miracle. I think the bottom line is it truly has been an emergent property. Things that it's been able to do. The best example of this for anybody who's even a little bit geeky was early on they found out that GPT, trained to do text work, could also generate an Excel script to create a budget, like the macros that were necessary. It could also program in Python. It was never trained to program in Python. And there's more and more of these behaviors that early on it was starting to exhibit, and it really challenged people. So bringing it back to us, you would not be surprised at all to think that these are the 6 main things we do with information in medicine. We generate messages, also known as inbox. We do ordering, documenting, searching, summarizing, and guidance, which is clinical decision support. It also won't surprise you to know that at least Epic has already announced GPT or AI-related tools in every single one of those spaces. And if any of you ever go to the Epic user group meeting, I go a lot, and I was there last year, this stuff is real. Many of us are piloting various pieces. I'm going to show you 2 pieces of it. So there's no question that if something doesn't go, as long as nothing goes wrong, all of the vendors will have access to tools that can do work to improve clinician efficiency, can do work to give us better data insights, can do revenue cycle work. That's actually the most likely to happen pretty quickly because of the risk-benefit ratio. We'll be able to do work with population health summarization, help with patient experiences, and then help with back office things such as capacity management. That's happening, not going to happen. These are some of the examples you can expect in the back office for people who are interested in that. Scheduling, one of my favorite issues. When I was CIO at Vanderbilt and I was in charge of bringing in our $500 million Epic install, which we did successfully on time and under budget, and built some innovation stuff on top of it. Thank you very much, I was very excited about that. And one of the things that we learned was this would be a great tool to help us with the open table scheduling problem, which is that we have 30 different types of orthopedic doctors, not all of whom are in the Department of Orthopedic Surgery. We have sports medicine, we have pediatrics who've been trained in both. Wouldn't it be great if our patients didn't have to specify the doctor, they could just specify the need? And we had systems that could identify the right doctor who maybe had an opening in their schedule. The biggest challenge with that was there was no incentive in our system for most of those physicians or nurse practitioners, advanced practice providers, to give us information about the edges of what they can do, right? And so they said, well, you know, if somebody finds me, yeah, I'll take it, but I don't typically see those patients. Well, with these tools, I can actually read their notes, and I can answer the question of what's at the edge of their skill. What do they see the most frequently? What else can they do? And I can use that to populate a scheduling system. So we were aware very early that that was a need that we were hoping some companies would be able to work on, and there are, you probably have all run into them, companies that have done that. There's also clinical decision support development, which is building language and explanations for why we should do certain things that this technology is going to be doing work on right now. There's a bunch of papers about that. It doesn't require a clinical trial, so you can expect to see it pretty quickly. There's prior auth, there's physician specialty analysis, and then there's quality measurements. So lots and lots of back office targets. Patient portal messages are here. So I will officially tell you, you will see clinical trials showing up in the next couple of years. We are doing one, UCSD is doing another. They actually have a paper that's out. This is the one that you see on the right, where what we are able to now do with generative AI is to take a message that your patient sends you, read it, actually with Epic, not just with Epic, but with Epic, go into the EHR and find some information that might be relevant and generate a response. Without Epic, it can at least generate a response that includes places where we might want to add other information. The typical types of questions people get are things like, I just received this lab result, what does it mean? GPT does that beautifully right now, and it does it in whatever level of literacy you would actually like to send it to the patient. So using a term called prompt engineering, which I won't talk about much, but I can, we can execute things like write this message for a literacy level or a readability level of 4th grade, no problem. It will come out and it will amaze you. Shorten this message by 50%. Remove all of the empathy. You can literally do all of that. It's what's called chain of thought prompt engineering. You may hear that phrase in the next couple of years. But people have now been using that model to create patient portal messages. On the left is some data from our work, and all you can see is a radar diagram, and I'll just tell you, we looked at a series of messages. We had only about 50 providers look at these messages that were generated by GPT, half, and generated by our actual physicians, the other half. And what you can see there is 2 different lines that are basically always the same. Those lines are showing how well people assessed the empathy, the relevance, the medical accuracy, and the readability of GPT patient portal messages. This is enough information. This is the 3rd study to come out about this, that there are now clinical trials where whole hospitals are doing at-scale analyses. And if you go to clinicaltrials.gov, you can see these. But many people are now testing this. So you will definitely, unless the studies go badly, be exposed to tools in your EHR systems that will generate your messages for you. The study on the right was one of the studies that I'll talk about it a little bit, but that's a study from UCSD that similarly said the same thing. Their study was actually a longer period. I think it was 6 weeks of actual use in clinic. And what they did was a series of net promoter score, but also time and motion sort of a study to determine that essentially using patient portal message response generated as much work for people to read, but significantly more satisfaction about the process of doing it. And that was because, to the point we were making, most of the time they didn't have to edit these. They were like, yeah, that looks pretty good. Maybe they changed one word. So all of the cognitive work that was required to generate a message de novo, and we all know what that feels like, was eliminated by this. So it looks pretty good. There are going to be some issues, and I can imagine what they'll be, but there's some others. The other one that's happening right now, and we had predicted that this might be the case, is chatbots. There are chatbot projects going on all around the country. And when we start thinking about the ways in which chatbots might actually help us with regard to either burnout or healthcare disparities, let's start with healthcare disparities. One of the biggest challenges that groups face right now has to do with the access problems we've already talked about. The data suggests that people do use social media as a part of what we would say is choice deciding. So if they talk to us and we say you can do A or B, they do typically go to TikTok or YouTube, and YouTube and TikTok are working on ways to develop a credibility score, some of us know about that, to ask the question. But they do still go to doctors and nurses to ask the question about what are the choices, what could I do, as well as how worried should I be about X, Y, or the prognosis question. A lot of that work could be embedded into a chatbot. Furthermore, everything that we've talked about with healthcare disparities could easily be today and is easily being generated through a chatbot. So imagine that your patient sees that before they see you. And that system asks questions about all of the issues related to where do you live, how are you handling food, in a non-judgmental way, with as much patience as is necessary, could be done at home. We can expect that over the next few years, because of the work that's now being done with chatbots, that you're going to see them in this issue as one of the ways to get around the disparities relating to access, as well as the disparities that cause problems relating to access. But they basically work the way you might imagine. There are some tools that are already out there. Geisinger's been piloting this. Vanderbilt's been piloting this in cancer. Penn has been piloting chatbots right now in genetic counseling is the main place that we're doing it. So genetic counseling for patients who have various variants and have questions about risk for certain types of diseases. I won't get into all of them. You guys know a bunch of that. So they're around, and you're going to see more and more access to these chatbots everywhere in the next few years. And if you go to clinicaltrials.gov, there's about 9 different major clinical trials going on in the country right now with chatbots, which means they've already established acceptability and feasibility, and now they're doing a larger study. Trials are also underway with this last one, which I think is the one that's the most exciting. Tools that do this ambient scribing. These are the results at Penn. How this works is you literally sit here, your patient and family can sit here, and you put your phone here. No computer necessary for this, and you have a conversation. These tools use basically internally built templates. Recall that at least 2 of these companies have had access to all of our dictated notes because they basically have been transcribing our notes for decades. So it's very easy for them to imagine what is relevant information for our notes. So you can talk about the football game, you can talk about the weather, you can talk about how hard it was to get into that house, how expensive real estate is in Napa, and that will be removed. Instead, it will talk about the main reasons why the patient is there, what you discussed, what you found, to the extent that you verbalize what you've seen on your physical exam, and create a note for you. Those notes, surprise, surprise, are less than 1/3 the length of the notes that we are typically generating, at least in early studies, very much like what we found from the study that David Bates and team published, but are generated within basically 2 hours of the patient being seen. It varies by how the organization has set it up. It's actually an organizational trigger, not a technology trigger, and that's a whole thing I could talk about. So the point is, it works. This is a study that actually is going on right now at Penn. This study is using data collected at our center where DAX was implemented among 67 physicians for 6 weeks, followed by a 4-week washout period after training. And what you can see at the bottom there, patient engagement, providers are reporting distraction from patient conversations due to documentation. Pre-DAX was 88.6, post-DAX is 13.6. Efficiency in care, time savings, average change in time in notes was basically 12%. Noticeable increase in provider sense of efficiency in terms of timeliness and reaching a satisfactory level of detail. Both move from neutral to mostly toward agreement. And then basically you can see the rest of the numbers. So basically the number one thing is people are not being able to use this to increase their patient volume, which they consider, if you were to talk to them, a good thing. Because they don't want someone to say that this will be an opportunity to squeeze 3 more patients per hour out of our clinicians because they no longer have to write notes. So far, that's not what the data are showing is possible, which is a good thing. The current version of this does not review the chart. It has the ability to add information, such as if you say you'd like to order certain medications, they are able to tee up those orders, queue up those orders, but there's absolutely nothing that prevents it from reviewing the chart. What I'd like to see them do, which is the research we're working on, is real-time review. I'd love to be able to have issues come up and have somewhere in the room a place where it's teeing up the report that I need to read to answer a question the patient may have asked that's in the chart. And that's doable, just not being done. And we could talk about why that is. So it's a really interesting technology that you can begin to imagine how you might want to layer on it, as you just said, Richard, to make it better. But it's working. The studies have to be done. There will be larger trials. And then I'll just quickly zip through this and say that, I and others have been working pretty hard to sort of think about what might this technology mean for the office of the future. It will definitely change it if we do what we're supposed to do. What are some of the differentiating skills of physicians and nurses who use AI? Recall my first comment from Kurt Langlocks, which means if this is going to happen and we have to have a human in the loop, how does that look? How do we deal with all of the issues that relate to how you get trained, whether you allow certain skills to degrade, or whether we have to do something not unlike pilots, which is go into a simulator to make sure we can still do what we do? And what will lifelong learning look like in the future? And this is, I did a podcast with Kirsten Bibbins-Domingo from JAMA and talked about that issue at length, and I have a couple pieces out there about lifelong learning. So that's the promise. It's kind of exciting, and if you knew nothing else about AI, you leave here thinking, this is going to be a great next 10 years, because these things will come out, the trials will be done. If these technologies are affordable, they're going to make our lives so much better. They're going to mitigate a lot of physician risk and nurse risk because we're going to be so much less burned out. But that's why I put this slide in. I need to mention, number one, that this picture was generated by OpenAI. This was a prompt that said, draw a picture of a person undergoing a challenge, and that's what it drew. So the major issue that we have to deal with can be summarized by this triangle, which I flipped on its side for space, which is the number 1 or 2 and 3 issues we deal with: people issues, process issues, and technology issues. These are basically drawn to scale, meaning the technology piece is the smallest piece and the easiest to solve. And here are the issues. The technology issue relates to cost, technology reliability, trustworthiness, and accessibility. The process issues relate primarily to the work that we're going to have to do to make those tools work is changing and reducing the existing complexity so that we have the bandwidth to use these technologies. And then the last is people, which is the giant gorilla in the room: skill, comfort, willingness, and cost. And we'll talk about some of that. So the hallucinations. I asked a simple question, and this was actually a 2023 test, which is, I said, what's a good reference to discuss human versus machine characteristics? Now, before you even look at the answer, let me just explain that the typical, we all hate the word hallucinations. There was actually a long conversation about, believe it or not, should it be confabulations? Because maybe that's a better word. The idea is that these are confidently expressed inaccuracies. Because remember, the way generative AI works is it's predicting one word or token given a series of other words or tokens, right? So if I ask it for what a good reference is, how likely do you think it is that it's going to actually return something from PubMed that's a good reference? Well, the answer should be pretty unlikely, right? So it's going to make it up because it doesn't actually try to compute. It doesn't, at least in 2023, know how to execute a search. It doesn't actually know that what you're asking at a metacognitive level is actually to find a particular piece of information versus a set of tokens. It didn't know how to do that. And so, not surprisingly, almost everybody's example of this is the made-up answer to a factual question as opposed to a theoretical conceptual answer, which is more likely to follow tokens because it represents the entire world of the internet. So here I ask, what's a good reference? It gives me this reference called, it looks beautiful, Human versus Machine Intelligence, how do they compare? By Kritika Gupta. If you then look online for that exact phrase, you can't find it because that wasn't written, but there are many things just like it by this author. So it made sense, and if you think about how it would have generated it, it makes even more sense why you should be testing this so that you'll start to understand what its limitations are. What's happened recently has been, again, the uncanny abilities of this technology. They've been able to use in OpenAI's tools and in Google's tools, they've been able to provide the manuals for searching using tools like Bing, and they have learned, the tools themselves, how to execute those searches when they're necessary. So if you now do a GPT search like this, you may say, performing Bing search. Or if I ask it to do a word cloud, it will say, using MATLAB. So it's now been learning there are tools on the internet that can actually solve the problem that you're asking. They don't have to generate the terms. How they're doing that, I have no idea. It is truly miraculous to me. I'm sure that if I talk to my friends there, they can explain it. But this is an example of a hallucination. The challenge with them is that when we start studying what's happening with the chatbots, which I've told you could look really interesting, these hallucinations do show up. They're not common, But when they're carefully evaluated, and I won't go through all of these data except to say that when we start to use more sophisticated methods to sort of narrow the space of an answer, one of which is this thing you see on the right called RAG, which is Retrieval Augmented Generation, fancy words for we give it a whole library of information in the prompt and say your answer is in here, we can essentially prevent hallucinations. But if you just say taking everything you've learned about every single language and every single internet accessible piece of information in the world, generate a conversation, there's a possibility that it will go wrong in some places in these chatbots. And so now the studies are about how do we mitigate that, and then how do we do trials to show that it's in no way dangerous. So active area of research. I'm not going to talk much about this, but I want to just mention that there are numerous considerations that are a part of the challenge. There is the whole idea of ethical governance, and I'll talk about that just briefly with some work DAM is doing. There's the issue of accountability and responsibility. We Tesla drivers know that there are way more people who drive through an intersection and get T-boned than the Tesla would ever allow. The question is, who do you blame when it's the Tesla? That's really the question. Then there's this issue of data privacy security gaps. There's issues of algorithmic fairness. That's another way to talk about the idea that the algorithm may not perform the exact same way in all settings, and therefore there is a built-in bias somewhere, typically in the data, but it could also be in the way the algorithms work. And there are experts around the country and the world thinking about how to improve that, which will make it more useful for groups of people who may be in some way marginalized. And there's lots of examples of that. If you ask me some questions, I'll be happy to give you some of the examples. Then there's this issue of transparency and explainability. And let me explain what that means. So the issue with explainability is this. We as clinicians want to know why you're thinking the thing you're thinking. There have been a lot of studies about this in the clinical decision support space, and when clinical decision support does not provide an explanation, even if no one actually even clicks the explanation button, it doesn't get adopted as well as when it does. And so we already know that rule-based systems needed explanations to get adopted. This is significantly more black box. And so the hope is that we will be able to develop an explanation. Why might GPT, OpenAI's version of those tools, why might it not be able to explain things? Because it doesn't actually know. It's using a series of tokens. So it's going to make up the explanation in the exact same way that it made up the answer. So neither is trustable, right? So what we're doing is trying to figure out new technologies that can actually help it to explain itself. But this whole idea of how do we help you to trust the answer as the person who's accountable is a big piece of the ethical considerations here. And then the last piece is informed consent. We don't know whether patients want to use a chatbot. We're starting to learn. We don't know whether patients right now like patient portal message responses that come from AI. So it would be wrong for us to be recommending something that we actually have never studied from a perspective of the patient or the receiver. So just note, AI right now could do and does do everything that you see on this slide. So we have technologies to do diagnostic work, we have technologies to do prognostic and predictive work, we have voice medical coaches, we have Apple Watches that detect AFib and heart rate issues and gait abnormalities, we have mental health detection tools, we have a ton of information going on in cardiology and mental health, those are some of the hottest areas. We have all of these imaging tools which have actually been present for really since the 80s, sometimes even a little earlier than that. So they're everywhere. And we know that if they're going to get any further, they are going to catalyze process changes. So remember, we're talking technology, process, and people. So from a process level, we know that those technologies that are everywhere, we aren't yet experiencing as a room. And for us to experience them as a room means that we've integrated them into everything else that they replace across our patient population, right? Which means if you are a patient with a healthcare disparity, if you are a patient with limited English proficiency, if you are a patient who has limited use of your hands, you have Parkinson's, et cetera, some of these technologies won't be available to you, which means we will have to continually staff for the lowest common denominator, even as we start to move groups further and further. And that's the new way we're thinking about the digital divide. That the problem is we leave patients with healthcare disparities of the other types behind, marginalized groups. But the current process is that we have people who are healthy, they have decline, we do interventions, we do recovery. You now start adding, and you don't even have to read the words here just to see, we now start adding all the ways in which new groups are a part of our healthcare system. And now add to that all of this. And that's what we have to be ready to do, to implement the technologies that you just saw. And now you add to that the issues of burnout. So now I have to get a workforce who's really interested in attending the meetings that are going to be required to build these processes, develop these policies and procedures, start to implement these technologies, and we have a real challenge in front of us. So, health AI literacy, which is a part of all of what this is going to take, still has to be taught, which means in addition to all of these processes, in addition to all these technologies, we have to get people on board to learn these things. So this is the care model. This is a group of staff who work in some random clinic, and these are the people who have to get past all of this technology while they're also thinking about this, which I know you all know they're thinking about, which is this stuff that you're training me to do so that I can actually lose my job? Because if so, I'm not that motivated to learn it, right? And so this is something we have to think about. There's a really nice piece that you see here on the right, which I'll be happy to give you guys from AHIMA. But essentially what AHIMA has been talking about is, if we're gonna build this smarter healthcare workforce with AI, these are what we have to do. These are the proactive steps. They carefully avoid this issue that's on the title here, which is, will it actually kill meaningless jobs, and will it kill other jobs that might be meaningful? The piece on the left is, I think, New York Times article that came out recently just describing this issue of there may be jobs that maybe people don't really want. And if we could figure out a way to remove those jobs, that would be great. The other thing is that if you look at that article on the right, you'll see it says we want to think about these jobs, changing the nature of how staff work at a hospital, changing the skills or competencies, requiring AI positions and technical talents that hospitals and health systems will need, demanding that leaders effectively manage change or create a culture that embraces innovation because of the concerns people might have about losing their job, and then dealing with this idea of facing significant objective and subjective barriers to adoption that we can overcome if we skillfully manage and plan it. I don't know that any of that's going to actually happen. This is what people are writing about. This is a real challenge that we all have to think about, all of us individually as well as groups. And that leads to the cautionary tale, so the AI winter. This is AI winter. So the AI winter phenomenon began in the 70s, where there was a tremendous amount of hype and actual experiments with limited computing capacity showing the enormous things that we could be doing with what was then AI circa the early 70s. None of the stuff that we're talking about today, the generative AI, was available in the 70s, though it actually was in the 80s. So what happened was that there was a period of time where this AI winter happened, and the reason that it happened was there was a lot of hype, followed by the failure to commercialize expert systems, which were the systems we were building, challenges with maintenance, too many specialized systems, think about the complexity issue, computationally intensive, and we didn't have the computing capacity then that we have now, and then very little attention to people issues that they knew could exist because that was part of why they chose the problems they chose. That resulted in decreasing funding. Many researchers who needed that funding abandoned the field, and it killed it. You'll notice in that picture there are two more AI winters, and there were different reasons for both of those. Work still continued, but actually under completely different names. And so that was where the terms machine learning came from, or ontologies came from, for people who know anything about this space. So it's been a long journey, mostly because of this loss of funding. And you might think, given everything that we've talked about, that there's no chance of that happening here. So I want to show you a little clip. We talked just briefly about health information exchange and the fact that it's been surprisingly low levels of adoption to get information from all of our practices available to any patients anywhere at the time that that information is needed, or providers anywhere that it's needed. So many people may know that really since the 70s, there have been efforts underway to do this. Actually, the UK has had a health information exchange for longer than anybody. The VA has had health information exchange within the VA hospitals for a long time. And there are multiple companies and multiple attempts here in this country to build an HIE. So I was a part of one that was in Tennessee. There's a documentary about it if you're interested in this on Amazon Prime, which I produced, called No Matter Where. And this is a clip from that documentary.
And in 2009, after much bickering, Congress agreed to set aside $19 billion to continue building this healthcare information highway. The first order of business was to convince everyone to stop using paper records. Stop it. So, the law set aside incentive money to help them install electronic medical record systems. This was like building the highway's on-ramps. Next, the government helped each state build its own section of the highway. These are the health information exchanges all those electronic records travel on. Once activated, these highways became alive, and for the first time, doctors could see their patients' full history at a glance. Oh, when it worked beautifully. In places like Indianapolis, Salt Lake City, and Memphis, where doctors called it, what's the word they used?
Revolutionary, actually.
Ah, yes.
Because we've never had patients' old records, or it's been very, very spotty if at best. I would hate to go back to candles instead of light bulbs, but that would be about equivalent to what it would be like. Makes a huge difference. We have a lot of patients, especially someone who's elderly and might be confused and might not actually be able to give you an accurate history whatsoever, so it gives you access to what their past history has been, and you can rapidly sort of focus in on the things you need to do.
Oh, sir, how are you? Again, my name's Dr. Nichols. I'm the emergency room doctor. I understand you're having a little difficulty breathing, is that right?
A lot of difficulty.
Yeah? Tell me about it. How long's that been going on?
Off and on for 2 years, but
So you've been running any fevers?
seem to be running a little bit.
Yeah, you having some chills, kind of some rigors?
Yeah, during the night.
He's got a complex medical history. He's been in multiple different hospitals. But I really need to take a look at his medical records, see what's going on. Because at this point, I don't know if it's pneumonia, I don't know if it's heart failure, which can both give you shortness of breath. We can pull data from other hospital systems and be able to look at overall how has his lung functions been, how is his kidneys working, has it gotten worse? And not just through our hospitals, but through all the other hospitals that he's been visiting. He's had metastasis to bone, so he's had cancer that's gone to different areas. Is there something else that could be going on today? All that information I wasn't able to garner from the patient, but I have to know that information to be able to make the right treatment decisions right now. Mr. Holderbaugh? Hey, sir. I was able to review your medical records. There's some important things in there that we looked at that's going to change a little bit on what we're going to do today. It took me 3 minutes of going through a medical history of all the different hospitals to be able to formulate a treatment plan for this gentleman immediately and be able to get him on the right track. Otherwise, I'm waiting for test results that are going to take me 1.5 hours to 2 hours, maybe even 3 hours. That's a luxury of time I don't have.
Those were heady days, but they would not last. Remember this doctor?
Revolutionary, actually.
Here he is, 2 years later.
You know, I don't even remember what my password is at this point in time.
I'm gonna go to my car and cry.
Okay.
So I show that to give you, by the way, not one, but there's 2 examples in this documentary of systems that failed within months of coming up, and probably a lot of other people have been a part of it. And I remember us being really crushed when we heard that, and there's reasons that are offered from the doctors about why it happened, but it's a cautionary tale that everything is looking really good until it doesn't look really good. And so what we have to think about to avoid another winter is something here. Pete Solovitz, and I won't read this in the interest of time, but I'll make sure I send you the reference to it if it's not in here. But Peter Solovitz at the MIT wrote a piece about essentially why science doesn't like miracles. In other words, why what's happening now may be thwarted by the other aspects of what science does. And the quote at the very bottom, I would urge great caution in adopting such methods. Now, this is a person who's been studying machine learning AI since the 70s. I would urge great caution in adopting such methods in healthcare, mainly because of our lack of understanding of how they accomplish the miraculous seeming things they're able to do. There's this article, there's a piece that came out from the New York Times, press pause on the Silicon Valley hype machine. So the AI winter version of this is out there. The question is whether we outrun it with other information and other belief and other implementations. Just to say a slide about this, there is a piece that's about to come out from the National Academy of Medicine. We'll make sure, if anybody reminds me, that we can get it to you. It's a new book. So this is what you're going to see coming out, AI Code of Conduct for Health, Healthcare, and Biomedical Science. There's a group of us who are part of the steering committee for this, and we've been writing it all summer. And a lot of this work that I've been focusing on has been lessons that are learned from the electronic health record, which largely succeeded, but if you read certain articles, will suggest some things that went wrong in terms of the unanticipated consequences of time shift and the note bloat and some other sort of hammer and champy stuff like re-engineering the corporation, where the idea of an electronic health record enabled many other activities that doctors were never supposed to be a part of. But long story short, those are all lessons we can learn to try to avoid what might look like really promising technologies from actually in some ways not achieving the level of opportunity we see here. This report mentions a lot of the components that need to be a part of the codes of conduct for other organizations that are in the healthcare space. I would encourage you all to read it. This is possibly the most important slide, which are the commitments that anybody who's thinking about AI has to think about, which is this idea of focusing on what humans and human connections mean, which arguably we are learning we're learning more and more about what we don't do as we're learning more about medicine. The benefits, the involvement of different groups of stakeholders, especially patients as partners in this with agency, workforce well-being, monitoring, and innovation. So lots of components. There'll be a nice report that will hopefully help you, as well as the government and other groups, to think about these issues. And with that, I'll stop.